This is an overview of an article entitled Dose Response of Beta Blockers in Adrenergic Receptor Polymorphism Genotypes, published in the August 2018 issue of Circulation, Genomic and Precision Medicine. Pharmacogenetics involves studying the relationship between individuals' underlying genetic variability and observed variability in the occurrence of beneficial and adverse effects in response to therapies. The study under discussion took a pharmacogenetics approach to examining potential variability in the response to beta blocker therapy, a common class of medication used for, among other indications, the treatment of chronic heart failure with a reduced ejection fraction. Part of the pathophysiology of chronic heart failure involves activation of neurohormonal systems, including an increase in sympathetic tone. Although compensatory initially, over time, this response becomes maladaptive, promoting adverse cardiac remodeling through detrimental direct effects of catecholamines on the myocardium. Numerous large clinical trials have in turn demonstrated beneficial effects of beta blockers in patients with chronic heart failure with reduced ejection fraction. It's uncertain, however, whether individuals' underlying genetic variation in genes encoding key elements of the sympathetic nervous system targeted by beta blockers could contribute to potential differences in therapeutic efficacy. Some of these putative gene products are shown in this figure, including the beta-1 adrenergic receptor, or ADRB1, and the alpha-2C adrenergic receptor, ADRA2C, gene products found at sympathetic neuromuscular junctions in the heart. Several previous studies suggested that genetic variants in these two genes might predict the relative benefit that individuals experience in response to beta blockers. These variants include the arginine 389 glycine polymorphism in ADRB1 and the insertion 322 to 325 deletion polymorphism in ADRA2C. It remains unknown, however, to what extent these genotypes might influence the potential efficacy of beta blockers at various doses. The investigators hypothesized that the efficacy of beta blockers in patients with heart failure might differ among those with the ADRB1 and ADRA2C polymorphisms as a function of beta blocker dose. To address this question, the investigators examined two populations in parallel. The first one was derived from the BEST trial involving the beta blocker bucindolol. In the original trial, unlike with most other beta blockers, bucindolol had failed to improve outcomes in a broad population of patients with chronic heart failure with reduced ejection fraction. However, subsequent genetic substudies of BEST suggested that bucindolol's efficacy might be different among individuals with different ADRB1 arginine 389 genotypes. The second population was derived from the HF Action trial, in which the ADRB1 arginine 389 genotype had previously been associated with mortality reduction among individuals receiving higher dose beta blockers. In the paper under discussion, the authors sequenced the ADRB1 and ADRA2C variants and examined the relationships between beta blocker dose and outcomes, stratifying patients based on genotype. In the first cohort, from the BEST trial, for patients homozygous for ADRB1 arginine 389, there was overall a 60% all-cause mortality reduction in the high versus no or low dose bucindolol groups. However, ADRB1 arginine 389 glycine carriers did not have a similar benefit, and statistical testing for this gene-dose interaction was significant, with a p-value of 0.035. Furthermore, ADRB1 genotype predicted therapeutic effect only for subjects taking high-dose bucindolol, with the no or low dose subgroups having similar all-cause mortality risk regardless of genotype, as shown in the graph. In the cohort derived from the HF Action trial, patients homozygous for ADRB1 arginine 389 also had a large reduction in all-cause mortality with high-dose beta blocker compared to no or low-dose beta blocker, in contrast to arginine 389 glycine carriers. However, in contrast to the BEST study findings, the genotype differentiated risk for those taking no or low-dose beta blocker, but not high-dose beta blocker. Specifically, in HF Action, arginine 389 homozygotes on no or low-dose beta blocker were at heightened all-cause mortality risk compared to arginine 389 glycine carriers, as shown in the graph. Of note, in both BEST and HF Action, there was no effect on all-cause mortality for high versus no or low-dose beta blockers when patients were grouped by ADRA2C genotype, the second gene investigated. In conclusion, for treatment with bucindolol and other beta blockers, ADRB1 genotypes and beta blocker dose significantly interacted with all-cause mortality risk. In both trials, high-dose beta blocker was much more effective than no or low-dose beta blocker in the ADRB1 arginine 389 homozygotes, but not in the ADRB1 arginine 389 glycine carriers. The importance of beta blocker dose might explain the lack of association between ADRB1 genotype and clinical outcomes among all beta blocker treated patients in prior studies. The authors concluded that an additional benefit of higher beta blocker doses for all-cause mortality might be present for heart failure patients homozygous for the ADRB1 arginine 389 genotype. While these data support guideline recommendations that beta blockers should be used at higher target doses in patients with heart failure with a reduced ejection fraction, the potential role of ADRB1 genotyping to assess the relative benefits of low-dose beta blockers warrants prospective study.